Okay, so we're going to talk about things used to treat anemia. We know that our blood consists of plasma. We have white blood cells, red blood cells, and platelets. Um, Erythropoiesis is the forming of our red blood cells, and erythropoietin is what stimulates that. I think I have pictures of how that happens. We've talked about that, but it stimulates is released from our kidneys in response to decreased blood flow to increase red blood cell production in the bone marrow. Okay. So the erythropoiesis is just the red blood cell formation. Here is a picture of that cycle. Things in order for us to have healthy functioning red blood cells, we need iron to help us carry hemoglobin. We need B12 and folic acid. Those are essential for DNA synthesis of every cell, and for us to be able to support. They provide a stromal structure, or like a supportive structure, in our red blood cells. Okay, so our red blood cells cannot function the way that they are supposed to. Hemoglobin cannot function the way that it is supposed to if we don't have adequate B12 or folic acid. And then amino acids and carbs make up the cell membrane and the structure of our RBCs. Okay, so we have different types of anemia. Iron deficiency, what's wrong? You don't have none. Yay, very good. We have deficient iron. So what labs am I monitoring for iron deficiency anemia? I'll monitor H&H because red blood cells are effective, right? What else am I monitoring? Mm-hmm. If you don't know anything about a lab, what do you think I'm monitoring? Iron, yay! So I'm checking iron levels. We're checking ferritin, we're checking transferrin, all those play a role. But that is helpful for me to know that those are going to be altered, because if somebody presents, if I just present, what does anemia look like? They're pale, they're fatigued, they're tired, they're cold. If they're Yeah, they may have brittle hair. If they present that way, they might be short of breath. If they present that way, yes, I think all of us got anemic when we got here, didn't we? But if they present that way, I see here there are different types of anemia, right? And so knowing if they go check their labs and their iron is normal, maybe that ain't the problem. Maybe it's not iron deficiency anemia. It's something else, okay? That falls in the hemolytic. Mm-hmm. So for megoblastic anemia, this is folic acid or B12 deficiency. Okay. Pernicious anemia, where they can't absorb B12, falls in that category. And then hemolytic anemia, we have sickle cell and thalassemia. Okay. Um, and again, identifying if megaloblastic involves folic acid and B12, what am I going to check? Folic acid and B12. If those are normal, that's not what's going on. Does that make sense? So if I don't know what's causing it, I'm not going to be able to treat it correctly. So determining that will be part of it, but I'm also monitoring their H&H, I'm monitoring their red blood cell, I'm monitoring their MCHC, I'm monitoring their MCV, which is the size of their red blood cells, the color of their red blood cells. So that way that can help me determine what type of anemia they have so we can treat it correctly. Okay. Um, so people at risk for iron deficiency anemia are people who menstruate, pregnant or lactating people, because they are sharing, um, growing adolescents, especially if they have nutritional deficits, and then if people have GI bleeds, including people who are like on long-term NSAIDs, and that's causing the GI bleed. This is relatively common, but here this isn't really a like dietary issue unless they're just not don't have a normal diet. This can be identified by a low iron, and then they also will have pale red blood cells. Okay. Um, the megaloblastic, this is to do with B12 or folate, and these will look like they'll have a lot of large red blood cells, but they're not functioning the way that they're supposed to. They're big, but they were immature. Okay. Um, One of the signs of megaloblastic is they have a red glossy tongue. They also could have diarrhea. Folic acid, this is very important for pregnant patients to supplement because they are at risk for developing neural tube defects in the baby if they are deficient. Most people do get folic acid from their diet. I have a list of things that show what contains folic acid. In order to replace these, we treat with folate or folic acid. Um, Things that can cause deficiency are malabsorption issues, malnutrition, especially if they're alcoholic, if they have repeat pregnancy, or if they're on some seizure medications. B12 deficiency can be caused by, vegetarian diet, or if they have issues with absorption in their GI tract. Both of these impair the structure of the red blood cells. So B12 is in meats, seafood, eggs, and cheese. Pernicious anemia is when they lack the intrinsic factor in order for them to use B12. That is important to know because you can buy B12 even over the counter. You can take oral B12, but if the problem is that you can't absorb it, I could take a whole bottle of it and that's not going to help me. So they're going to need to take that IM. Important to know um, you cannot give B12 IV. Um, I would just say close together. I'd say either I'd say either of those would, yes. I mean your body doesn't have time to recover. So I would say yes. That is above my knowledge. I would say minimally a year. But who am I to say that? And probably more so if this is like even more than one. Like I've been pregnant back to back 4 times. That's going to take a bigger toll versus even just 2 pregnancies, if that makes sense. Um, huh? Yeah. Um, So for B12 deficiency, that'll look like fatigue, lethargy, and in addition to those side effects of normal anemia, neurological impact like tingling or because it damages myelin sheaths is something that you will notice. At one time, that was deadly. Like if you had this, you would just die. But now we are able to treat with parenteral or nasal B12. All right. Megaloblastic anemia usually occurs when there is insufficient folic acid or vitamin B12 to support the stromal structure of the red blood cells. True. Very good. All right. Um, For iron, kids may need supplements as they go through growth spurts. Everybody is at risk for iron toxicity, but children are going to be at a greater risk. Very important that we monitor their dosing. If they are using an oral supplement, very important to teach them to use a straw if it's liquid because it can stain their teeth. Um, Very important, period, but especially if that's permanent teeth. They need to have their blood rechecked every 4 to 6 months. There is risk for toxicity, which would look like GI issues, vomiting, abdominal pain, diarrhea, drowsiness. If it is severe enough, it can be low blood pressure, seizures, coma. If they're presenting with any of those things, we need to check their iron levels. For adults, be dependent on what kind of anemia they have, and then make sure that we are monitoring older adults for kidney function and severe constipation. So where these drugs act are going to be dependent on what kind of anemia they have, what we're using to treat them. Because the kidneys produce the erythropoietin, that is a site that can be impacted, the bone marrow to stimulate the production, or circulation where those are carried. And I think I'm referring to this picture that's on page 883. All right, so we said how erythropoietin works. This is a picture of that from your book. So we can, if their body can't produce enough erythropoietin, then we may have to supplement that. It is important for you to know that in order for erythropoietin to work, they have to have iron. So we will need to supplement or make sure that their iron levels are normal in order for this to work. So the more common medication that you will see is epoetin alpha or Epigen or Procrit, which is basically just like an artificial erythropoietin. It is stimulating erythropoiesis. Okay. These do carry black box warning for increased risk of death, MI, stroke, thromboembolism, and the recurrence or progression of tumors. And it makes sense if you think about it, because it's encouraging the production of red blood cells. And so if there's already a problem and I'm adding more, I'm increasing the risk for that. Okay. So it acts just like normal erythropoietin to make red blood cells be produced. It's not used for other type of anemias. This also isn't used as an alternative to blood transfusions or for like an emergent treatment of anemia or hemorrhage. Okay. It is commonly used for patients, this very common for patients who are on dialysis. They have to have Epigen, okay, because their kidneys aren't functioning the way that they're supposed to. So treats anemia with chronic renal failure, side effects from HIV medications, or chemotherapy that suppresses the bone marrow. It is contraindicated in uncontrolled hypertension, where adding more blood volume would cause issues. And again, it can cause growth of tumors, so we need to use that cautiously. It can be given sub-Q or IV. It is very important for us to know that they're lacking this before we give it, because if I gave this to somebody that's not the cause of their anemia, then I'm supplementing it, and once I supplement it, the body's going to say it doesn't need it, and then it's not going to produce it. Okay, so then they would have an issue. So very important for us to identify the cause. Adverse effects of these: headache, dizziness, fatigue, nausea, vomiting, diarrhea, a risk for chest pain, high blood pressure, the increased risk for clots or cancer growth. Very important not to mix this in solution with other drugs. So I'm not giving this in the same line with other medication or mixing it as a sub-Q injection with anything else. There is risk for clotting in the line if giving it IV. The note I have here is that this is on page 884 and 885. So we want to make sure that we're monitoring their blood pressure, their hemoglobin levels, and that their iron is adequate so that it can work. And here's a little picture that I put there. I don't think there's anything else that I wanted to say about that. Just might be helpful. All right. For iron deficiency, we're going to give them iron. The different preparations for this are, a lot of them start with ferrous. So ferrous, fumarate, gluconate, sulfate, iron, dextran, sucrose, or sodium ferric gluconate complex. The goal is for us to increase their iron in order to support hemoglobin. So it can be used to treat iron deficiency anemia or treat anemia associated with people who need erythropoietin stimulators. It is used in conjunction with diet, and the drug depends on what the patient needs and the provider's choice. Contraindication, if they're allergic, there is a huge risk for anaphylaxis with IV or parenteral iron, so you have to be very careful, monitor for that. If they have a history of that, don't give it. If they already have a very high iron hemochromatosis, we don't want to give this. And then if it's not iron deficiency anemia, also we wouldn't want to because it could become toxic. There is a risk for it to irritate GI tissues and cause exacerbation of GI diseases like peptic ulcers, colitis, or enteritis. So this is broken down here by the different administration types of what effects are associated with those. So oral iron, one of the biggest complications from iron is constipation. And so very important for us to teach patients. They may need a stool softener, excess fluid, fiber. They need to get up, move around. This also can make people have black stools. So if your patient calls and says, hey, you just started me on this medication, I'm freaking out, my poop was black, what are you going to say? That's normal, right? Now, what if my patient on Coumadin calls me and says, I'm freaking out, my poop was black? Get your butt here and stop taking it, right? Those are two different things. But this would be considered normal and something they need to know ahead of time. It also can cause nausea, vomiting, and just like GI, ugh. If it's a liquid form, they need to use a straw because it can cause teeth staining. If we're giving it IM, they need to use Z-Track method. We don't give it sub-Q. Do y'all know about Z-Track? That's right. I move it, I inject, I let it go, pull out, right? I'm getting rid of it. Okay. The parenteral is when they can't tolerate the PO, and it could be more beneficial in patients who have chronic kidney disease. It can be painful, IM, so oral or IV is preferred. It does take a long time for it to go into effect, usually about 2 to 3 weeks to even see effects, and then up to 10 months for it to return to normal. If they do develop toxicity, we can do chelation. I will show y'all. I have a slide on that. It's basically, it binds to the iron and gets rid of it. Okay. The drugs here, you don't necessarily need to know that. I would say know that the antacids, calcium, magnesium, tetracycline, cimetidine, those need to be given 2 hours apart or they can cause a decreased iron level. And then these other medications are, again, other antibiotics that need to be given 2 hours apart. We can also dilute this in water or juice. And vitamin C can increase the absorption of it. So, and the problem with vitamin C is it also can cause GI upset. So if you're taking both of those together, could cause worse problems. So eggs, milk, coffee, tea decrease the absorption of iron. Vitamin C or more acidic things increase the absorption. So I definitely don't want to tell somebody to take this with milk, and take it between meals for the best absorption. You can't. It really is sad. Um, and then I have that this is on page 888. Okay, here are different things that you can look at. I think I said all this, but this might be helpful to you. All right, megaloblastic. So folic acid, a lot of times this is just folic acid, folate, whatever. Regardless of the form in which this is given, one thing that is interesting is that some of these can be used to decrease the toxicity or almost as a reversal to immunosuppressants or chemotherapy. Okay. Um, and then B12, that looks like hydroxocobalamin or cyanocobalamin. That is the name of those medications. I've said what those things do. They would be contraindicated if there is an allergy for the nasal form of B12. If they have some sort of irritation, ulcer, something in their nose, obviously that would be contraindicated because it would make it absorb more. Folic acid can be given oral, IM, IV, or sub-Q. The parenteral forms or for people who have absorption issues. And that's the same for B12. If it's for absorption issues, they do need the injection form or the nasal. They can develop skin reactions, GI issues, or pain or discomfort at the injection sites. In order to assess for these, neurological status would be one of the things that would set this apart from the other anemias. We're also monitoring pulse, blood pressure, perfusion, their affect, respiration, CBC, hematocrit, B12, folic acid, and we'll also measure iron because I wouldn't suspect that their iron would be low if this is the case. Here are some symptoms of folate deficiency, which vary from iron deficiency anemia. And then here are the prototypes. So the cyanocobalamin, which can be given for pernicious or megaloblastic. I think I said this. They cannot be given IV, have to be given IM. And if it is for absorption issues, they can't take it orally because they can't absorb it. This is just what folic acid does. So obviously they would have consequences of this if they are deficient. In pregnancy, there is risk for neural tube defects. These are things that contain folate and folic acid in order to supplement those in our diet. B12 deficiency, here are some of the things that can cause that, and then signs and symptoms of that, again, just to distinguish between iron deficiency or like sickle cell anemia. Folic acid and B12 should be used only with caution in pregnant and lactating patients. That's false. We got to give folic acid to pregnant people, right? Yes. All right, very good. All right, so hemolytic and aplastic. I'm gonna be quick. It's gonna take me 1 minute. So sickle cell is hydroxyurea is our drug that we're gonna talk about here. We're skipping over vaccine, and then aplastic is treated with immunosuppressants and then corticosteroids. So don't worry about that. That's right. I'm sorry. Y'all don't do nothing. Y'all don't do nothing. Um, the hydroxyurea, this is promoting hemoglobin production in bone marrow. Okay. These other things we're not worried about. The contraindication will be allergy, pregnancy, hydroxyurea. We want to use extreme caution if they have severe anemia, leukopenia, or impaired renal or liver function. The side effects, GI effects, skin reaction, bone marrow suppression, headaches, and fever. Here is the drug card for that. The purpose of hydroxyurea is that they basically are at the end of their rope of like they've had these recurrent, very painful crises and have had to have blood transfusions when they have sickle cell. This would definitely not be, this isn't for everybody who has sickle cell. Um, so times would be where it's very painful, occurring very often. They have like a history of clotting or necrosis from it, very symptomatic, or at a high risk or have a history of stroke. And bone marrow suppression is what we would be worried about, which would put them at risk for regular anemia and decreased platelets and decreased white blood cells. Okay. So very important. Sickle cell in general, I talked about this in patho, but I will just say treatment for that really is getting them hydrated, controlling their pain, getting them some oxygen. Okay. The hydroxyurea is what we are doing if controlling that doesn't work or as it progresses. IV fluids. I can't remember if I said that. And then this little slide is just maybe easier for you to look at of like the specific kinds of what we're going to do about it and what causes it and what it looks like. The end.